Good morning. Καλημέρα. We're going to do this, το κάνουμε στα αγγλικά για όλους και για τους international speakers. So it's my pleasure to chair this session with Dr. Karakatsanis. I'm Terry Mamones, breast surgical oncologist, working in the US in Orlando, Florida. So we have a debate this morning for a very important topic that we all struggle with. And this is the debate of axillary surgery after neoadjuvant chemotherapy. And the debate is whether clinically not positive patients who have converted to clinically negative after neoadjuvant chemotherapy, and then they have a positive sentinel node, either by sentinel lymph node biopsy, targeted axillary dissection, should they have an axillary lymph node dissection, a completion axillary lymph node dissection? And there will be a pro and con debate. So our first speaker, which will argue the yes approach, is Dr. Aggarwal. He's a consultant oncoplastic breast surgeon in Cambridge. He's a member of the academic, look at it here, Academic and Research Council Research Committee, Associate of Breast Surgery in the UK, and founder and director of Cambridge Perforator Flap and Implant course. Dr. Aggarwal will again argue the yes approach. Welcome.
Thank you. It's a pleasure to be here. Many thanks to Hellenic Society of Breast Surgery for inviting me. I'm not going to be debating, I'm going to be discussing actually, because it is such a conflicting topic actually. So I do not have any conflict of interest, but the debate itself is conflicting, I guess. Now, if I may take a few steps back as to where we started with de-escalation trials in axilla, and we are all aware of a number of trials looking at ITCs, micrometastasis, and macrometastasis in non-neoadjuvant chemotherapy setting. So nobody does clearance for ITCs, nobody does or should do for micrometastasis. For macro, of course, most likely more of us do nothing, but majority of these patients do get radiotherapy, and there are several cautions, if I must say before I go on to the next step. All of these trials cater to 2 or less lymph nodes. Biology were not explicitly stated for intention to treat analysis because they were all-comers biology. Likely majority were ER positive, HER2 negative because they didn't receive neoadjuvant chemotherapy, so they were lower risk biology. Now, all these trials they've reported, probably AMRAS and Z11 are the ones that have reported up to 10 years. Maybe they might be coming up to 15 years now. Now, we do know in ER positive, HER2 negatives, we do see late recurrences. So have we seen long enough follow-up in non-neoadjuvant, lower volume, lower risk disease before we jump on to higher volume, higher risk disease, which do need neoadjuvant chemotherapy? And strictly by definition, if you talk to the purist in pathology, they would say complete response is only if there are no ITCs or micro or macro metastasis. So there are several issues that we need to discuss. I don't think we are going to get a conclusion today, maybe, but then can we discuss a few things before we vote? Now, about diagnostic imaging, are we happy enough with our current diagnostic imaging? Assessment or response in the breast is not perfect yet. Not to mention about axilla. This, the first one that you can see, looking at the MRI, positive predictive value was highest in ER negative and HER2 positive in breast. They don't talk about much of the axilla. The second one, the PET scan, it showed higher sensitivity and specificity than MRI for assessing breast response. There's no nodal data. Now, there may be future predictive models. I think there's some study going on with some AI professor in Greece. It's kind of using predictive PET models to predict path response in the lymph nodes. And preliminary data suggests that triple negative and HER2 positives are more likely to be responsive, which is kind of an obvious, than luminals. Now, but then we don't do preoperative PET, we don't do preoperative MRI, etc., to look in the axilla, we have preoperative ultrasound. So are you confident, are you happy with your radiologist who's reporting, do they have inter-observer variability? Because when you are looking at clinically node negative or positive after chemotherapy, you have got to be certain which route to take. Then we are debating after. Sensitivity, if they look at one abnormal node, is 66, specificity of 77%. Preoperative MRI study, MSK, Monica Moro's, I think, group, they reported 35% false positive. So you have given chemotherapy, 35% patients would be called positive, clinically node positive, wherein you might do clearance. If they are called negative, you may not do. So there's that discrepancy over there. So we haven't quite got perfection in the axillary diagnostic imaging yet. There's lack of standardization in how they report. There's lack of accuracy in restaging. MRI, there's very early experience. PET, it's very early interest. Maybe in future, radiomics and AI might help. But the dilemma remains, how do you accurately differentiate, discriminate between node positive or node negative after chemotherapy for us to be able to decide whether to do sentinel node or targeted dissection? Then we get the question of positive or negative, and then we debate about clearance or not. Now, how about neoadjuvant chemotherapy indications and response? Chemotherapy initially, at least to a surgeon, was to downsize breast tumor size and downstage T of the TNM. But do we need to really give chemotherapy to many of these patients who used to receive chemotherapy in the past? In the era of oncoplastic, we don't need to. But then one could argue chemotherapy neoadjuvant is to downsize axilla, right? Downsize axilla. Now, if we are dealing with non-neoadjuvant chemo setting, node negative, no chemotherapy, if we get more than 2 positive lymph nodes, our tendency is still to do clearance, because none of those trials, as I mentioned about Amaras or whichever, they included more than 2 lymph nodes. And now we are talking in node positive setting, higher risk disease, where we're giving chemotherapy, and they remain positive, meaning chemo didn't quite work or didn't completely work, and then we are questioning clearance here. But of course, chemotherapy is not to downsize axilla, it's to downstage. How do you know you have downstage? If you don't even do clearance, you are still stuck at 1 or 2 or 3 lymph nodes, because strictly going by TNM classification, you've got to take a certain number of lymph nodes. If you don't do clearance, then you don't get that information. But then we can look away. We look away, we are all fine, from any problems in the world. And there's axillary intelligence, it seems, to auto downstage, because you don't look, it's already downstaged. What does happen in the undissected axilla? Now, there's a recent study. While prepping, actually, I came across this study. 1,900 patients, they found 26% additional positive nodes, 37% macroscopic, single center, single database, agreed. What was interesting, they say additional nodes were found in older age, T2 category, grade 1, ER positive, HER2 negative, lobular multifocality. Now, should these patients have received chemotherapy? So we're asking we're doing something not right, and then we're creating a problem, then we're asking what to do after chemotherapy. So that kind of proves the point in a way. And statistically speaking, I think it's called type 3 error. Now, meta-analysis of 2,200 patients, axillary path response rate was 37%. Another meta-analysis, 4,500 patients. They didn't quite talk about path complete response. They looked into different various methods of identifying with good identification rates. Now, could the response be burden related? As in, the more the tumor, the better the response, the less the tumor, the less the response. Well, this meta-analysis, again, identification rate of 91%, great, but they show that there was less complete response if the tumor burden was higher. So if you start off with C2 and 3, and this is, I'm playing with the topic I was given, because nobody told me C1. I was told clinically node positive. So if clinically node positive N2, N3, and if we were to give chemotherapy, should we even debate about this? We're talking about C1. Now, another residual nodal burden kind of prediction, looking at targeted dissection a step further, they found 27% patients had 4.1 additional lymph nodes. Now, in Cambridge, if a patient has 4 or more lymph nodes, we tend to stage them because then they have got higher risk of metastatic disease. And that's where oncologists will jump in and give CDK, etc. But then we don't want to jump in. I'm going to... Now, original study, Monica Moro's group, when they looked at 702 patients, 17% of ITCs and 64% of micrometastasis had additional nodes or lymph node dissection. Single center and this frozen section, so maybe there's a caveat over there. So maybe not doing clearance in ITCs may be okay, but perhaps not in micrometastasis. Is there any data on ITCs? Now, this is EU breast study, OPBC ICARO. What they looked into population study of residual ITCs, clearance versus radiotherapy versus observations. 35% clearance were more likely if the surgeon was told it was N2, N3, LVI plus frozen plus disease. And when they did clearance, additional nodes were seen in up to 30%. So no clearance in ITCs, but probably it also means that it should be supporting clearance in micro and macro metastasis. Is there any data on micro? There is a study ongoing, the same group, 06 study, which is recruiting. In future, we'll have Alliance 11202 data and ADANET, which is a Spanish data. I'll go into a bit of detail a bit later. Other predictive nomograms, so we know better before we make the decision even for sentinel node or clearance, before we get to the point of sentinel node positivity. MD Anderson as Japanese cohort, again, very similar, grade 3 HER2 positive ER negatives, they do respond, they will respond in the breast, they will likely respond in the axilla. Now, oncologists would probably want you to operate, do clearance because they need information for CDK4/6 inhibitor. Perhaps not. There was some recent data. I haven't quite got into details. But if they ask you to do clearance, Jana de Boniface in Cenemet trial, she published very recently in Lancet Oncology, say that you have to do 104 clearances to gain 1 disease-free survival. So I'm actually talking against clearance here. But the point is, oncologists is asking you to do clearance to gain information about CDK4/6 inhibitors. But do the surgeons want to do clearance? American Society of Breast Surgeons, a survey done by Boy's Group, 15% surgeons responded. So 85 didn't want to offend probably the PI, so they didn't answer. And what surgeons were doing was they were less likely to omit clearance if they found C1 disease rather than C0 disease. So if they start with node positive chemotherapy, node positive, they're kind of less keen on doing clearance. Michaelis Kontos from Greece, from Athens, he did a TAD survey, targeted dissection. 42% of targeted dissection found 1 to 3 nodes. Now, again, similar kind of profile, HER2 positives, triple negative surgeons would probably more likely to conserve axilla, but the rest wouldn't. So the oncologists wanted to do the clearance, but the surgeons are saying, no, we're not doing clearance because we're already convinced with the evidence. So how is why are the surgeons so unkeen? Perhaps it's to do with how the trainees are trained now. We do clip lymph nodes or mark the lymph nodes before chemotherapy with a number of methods, not going into the details, carbon-tatty, Maxid, etc., etc. Is there a difference between sentinel lymph node and targeted dissection? This is again population data, OMA study. What they found was targeted dissection, there were 3 lymph nodes. And sentinel node median was 4 lymph nodes. That's kind of, I thought it was interesting, probably something called Hawthorne effect, which means if you are watched, if there's a CCTV, you tend to behave better, don't we also? So maybe when the surgeons were doing targeted dissection, they were taking less lymph nodes, because in my mind, I thought targeted dissection, the word itself may mean more than 2 sentinel lymph nodes, because the average for sentinel node is 2, but in real world, it's 4. Now, Taxis trial, which is run by Walter Weber, what it's looking into is, could there be something in between clearance and targeted dissection? So they're calling it TAS, targeted axillary surgery, which does include biopsied lymph node, clipped lymph nodes, sentinel lymph node, suspicious lymph node, and radiotherapy. So, what's the problem with level 1 clearance? Because there's a lot being dissected over there, plus radiotherapy. But then this is a study that we'll look forward to, we'll have the data in future. False negative rate of TAS was 2.6%. Image-guided localization doesn't seem to improve outcomes. Aksana study by my learned opposing counsel will probably be talking later on, looking at different methods of axillary sampling, shall we say. So if we don't do clearance, what are the alternatives? Of course, the alternative is radiotherapy. Radiation oncologists, of course, can shrink everything, but then they don't like if you tell them positive margin is present, macroscopic disease is present. They don't generally tend to like it. Now, what I found it interesting, while we are fretting over lymphedema, all the complications, we are very kind of complication savvy. As surgeons, we look at the negative side of things, and we're trying to improve things. But how many trials have endpoints as side effect? Maybe the recent radiotherapy trials are having these endpoints, but then all these traditional, older trials, 10, 15 years old or longer, they don't report on side effect. EBCT-CG group presented more than 15 years survival. Of course, we know that. They say there's excess contralateral breast cancer due to radiotherapy, lung cancer, heart disease, etc. Having said that, the risk they quote is longer, 15 to 20 years later. We haven't even got trial results longer than 5 or maybe 10 years. We are giving radiotherapy to these patients. Do we need to wait, or do we need to change our practice right now? What I found interesting is in the middle row, the red one, 4.5% in N2, absolute reduction in 15 years breast cancer mortality. Of course, N2 is, if only you do clearance, then you know it's N2 or N1. When we do implant surgery, we talk to the patients about anaplastic large cell lymphoma. We have to talk to them. The maximum incidence is 0.3%. But do we tell the patients that you're not going to do clearance, you'll prevent lymphedema, but actually this is the radiation therapy-induced sarcoma incidence, which is higher than ALCL. But do we talk to them? Do the oncologists, maybe they talk, I don't sit with them, but then do they talk? And it's poorer prognostic. And we are seeing them late angiosarcoma because patients are living longer. And Z11 itself, when they did a subgroup analysis, they say substantial minority received extended nodal radiation. So whilst you're reducing clearance, you are escalating radiotherapy fields. And they say further research is needed. Now, radiotherapy seems non-inferior in those who turn node negative, NSABP 51 trial. It did take larger tumors. I'm not going to go into details. Now, the specific trials that are ongoing in this setting, node positive, on sentinel lymph node biopsy, Alliance 11202. What it's looking at, arm 2, I find it easier to understand, no clearance, along with breast or chest wall radiotherapy, plus nodal irradiation level 1, 2, 3, and SCF. So 1, 2, 3, 4. Versus clearance level 1 and 2, and the rest of the field irradiated. So it's an ongoing trial. They do exclude N2 and N3. So we need to be careful. If we are saying no to clearance, then you need to be careful who you are selecting, C1, C2, or N2 or N3. ADANA trial in Spain is another randomized trial, clearance versus radiotherapy. They include neoadjuvant endocrine therapy, and that I find it interesting. Maybe these are the patients in ER-positive, HER2 negatives who we may have some data in future. Now, so the conclusion from RT aspect is there's no robust evidence yet, perhaps in future. If for good prognostic ER-positive tumors, would the RT benefit sustain long enough to offset noted late recurrences that are happening 15 to 20 years later? And these are the patients who used to receive 5 weeks of radiotherapy in low-risk ER-positive tumors. What about the long-term side effects, fibrosis of the breast, if you are conserving the breast? That's again is long-term. If for good responsive tumors, triple negative and HER2, would the radiotherapy add on top of very good effective systemic therapy? Improving ALND, being a surgeon, can we improve on what we do so that we worry less about lymphedema? Axillary reverse mapping, this is something has come up where they map out lymphatics from the arm and lymphatics from the breast and try and see if they can avoid the arm lymphatics. It seems to have some success in non-neoadjuvant chemotherapy, but in chemotherapy setting, there's some limited success and probably untested because we are de-escalating a bit too fast, too soon. So we'll probably wait for the data, but whilst we are focusing on de-escalating, what we need to do is not to forget about the prevalent lymphedema. There are several ways you can prevent lymphedema before it really happens, rather than to de-escalate when there's no oncological evidence to de-escalate. There could be future stem cell mesenchymal cell transfer, which allows, and there's some lab data to say that it could lead to regeneration of lymphatic networks. So maybe we can do something else whilst not fretting about or compromising oncological safety. The final few slides to close the matter. Now, I did a clinical study looking at how the radiologists look at the lymph nodes versus what the features are on the breast. It's a retrospective single-center study. Interesting found was tumors that are closer to the skin, they tend to have more node positive, even if they are lower grade. And we see that in clinic. If we get ER positive, low grade, and node positive, whilst triple negative doesn't. So that could be one of the reasons. But second, lymph node is an immunological organ. We are de-escalating based on numbers, N1, N2, N3. We're not talking about the science behind it. And the lab data, collaborative data with Professor Mahata in Cambridge, there is some difference in immune profile of node positive versus node negative, wherein there's a shift about T regulatory cells. So there's more to the science before we jump into de-escalating. Now, pro-clearance, there's plenty of evidence, plenty of history. We are in Athens. We can't ignore history, so let's stick with it. Against clearance, we'll learn soon. So why do we need to do clearance? Number one, to prognosticate, as lymph node remains the single best variable when it comes to prognosis. Number two, we need to stage, because more than 4 nodes, we know whether the patient is high risk for METs or not, so that oncologists can escalate post NACT treatment. ER positive, HER2 negative, we need to wait longer for late recurrences before we can conclude, should we be giving them an neoadjuvant chemo? Does radiotherapy actually eradicate all the disease? If it eradicated all the disease in breast, we would never have local recurrences, but we do see local recurrences in ER positive and HER2 negatives. Could radiotherapy fields extended beyond N1 lead to extended risky exposure? We don't know. I'm not an oncologist. So we do need to know undissected axilla, because more than 25% are positive. There's more lymph nodes in T3, non-complete response, non-HER2, non-triple negative, will allow identification of neoadjuvant chemo-resistant tumor clones. If they haven't responded, something is bad. But if you don't dissect, you don't get that information. And if you don't need that information, then why are you escalating if you're with CDK, capecitabine, TDM, etc.? So with that, I'm going to rest the case in favor of clearance. Thank you. If you want to escalate, then you enjoy casual date. If you want to de-escalate, then fine, you can jump. Thank you.
Thank you so much, Amit, for that. Now we'll go for the opposite opinion, and I'm very happy to present Torsten Kuhn, professor from Ulm University in Germany and president of the EU Breast. Torsten needs no introductions. He will be talking to us about the no side of things. Torsten.
Yeah, ladies and gentlemen, dear Chairman, first of all, let me thank the organizers to invite me to this beautiful place. It's a real pleasure to come. And it's probably not so easy to convince the community of surgeons to omit axial lymph node dissection in patients who initially had a positive lymph node status, then converted to clinical node negativity and had still positive lymph nodes. But I will try to do so, since I'm convinced of that. These are my disclosures, and please note that I am a surgeon. So this is a paper I published almost 25 years ago, and we asked patients who at that time, all patients underwent full axial lymph node dissection, and we asked these patients for the most bothersome problem after breast cancer treatment. And by far, the most important problem was arm problems, and it was rated higher than fear for cancer recurrence and also higher than any aesthetic problems, including mastectomy. So avoiding axial lymph node dissection wherever we can is an important issue. Now, we all know guidelines, and I think guidelines are the same all over the world, and these are German AGO guidelines, probably very similar to your guidelines. In patients who convert from node positivity to node negativity clinically, then undergo central lymph node or targeted lymph node biopsy and have a positive lymph node status, YPN1 micro or macrometastasis, we recommend axial lymph node dissection, awaiting randomized trials from the Alliance trial. So we have to recommend this because we do not have any data from randomized trial for omission of axial resection. And for patients with isolated tumor cell, we have a plus. So this is the plus, this is the recommendation, plus minus, meaning according to our guideline language, we do not know if we do more benefit than harm with the procedure. But was this done in clinical practice? And these are data from the AXANA study, and I'm very happy and thankful that so many Greek sites participate. So we have, at the time of analysis, 4,300 patients from 26 countries and almost 300 study sites. And 2,100 of them had completed surgery and had undergone target axial resection or central lymph node biopsy or target lymph node biopsy. So we had an overall complete response rate of 56.5%, and 32.5% had YPN1 to 3 stage, 7% had micrometastasis in the central or target lymph node, and 2.3% had isolated tumor cells in the central or target lymph node. Now, what is done in real-world practice? You can see that for patients with macrometastasis, almost 25% of the surgeons omit axial resection today. They doubt if this procedure is of benefit for the patients, even in the absence of randomized trials. For patients with micrometastasis, more than 50% do not perform axial resection anymore. For patients with isolated tumor cells, almost 70% of surgeons do not go for axial resection anymore. Now, we all know data from the AMOROS trial. 10-year data is published in 2022, comparing in the upfront surgery setting, positive sentinel node axial resection to radiotherapy. There was no difference with regard to any oncologic outcome. Whoops. But there was a clear, significant difference in arm morbidity, in arm edema. So, however, the elephant in the room is, can we translate data from primary surgery to the neoadjuvant setting? And there's some concern. First of all, these are data from Tracy Moore published in 2018 showing that after neoadjuvant chemotherapy, the rate of non-central lymph node involvement is much higher compared to the upfront surgery setting. In upfront surgery, we have, in patients with micrometastasis, we have in 18% additional lymph nodes. But if we have a micrometastasis in the central node after neoadjuvant chemotherapy, the rate is 64%. And so we do not know if omission, in upfront surgery, we omit axial resection in these patients. But we are not sure if in these patients with a much higher tumor burden after chemotherapy, we should not go for axial resection. This was the conclusion of the authors of these papers. So we simply do not have data. The next hypothesis is that argue for axial resection is that chemo-resistant cells are resistant against radiotherapy. But why should they? Are chemo-resistant cells resistant against endocrine treatment? Are endocrine-resistant cells resistant against chemotherapy? So why should chemo-resistant cells should be resistant against radiotherapy? Well, with regards to axial resection, please know this is the meta-analysis of an early breast cancer collaborative group from 2005, showed that never ever in history axillary dissection had any positive effect on oncologic outcome whenever radiotherapy was in some way part of the treatment concept. So axillary dissection has very limited or no therapeutic effect. Now, with regards to the hypothesis that chemoresistant cells might be resistant to radiotherapy. So this is a study addressing this issue, and as you can see, for patients who have a good response in the node, there is certainly effect of radiotherapy here to the chest wall. But for patients with residual disease in nodes, the effect of radiotherapy to the chest wall is at least similar, but if not higher, showing that radiotherapy is effective in chemo-resistant cells. And this is a retrospective study addressing exactly the topic that we are talking about. Should patients with a positive central lymph node or target lymph node after chemotherapy undergo axial lymph node dissection or central lymph node biopsy alone? It is retrospective, sure. 161 patients, 53 central lymph node biopsy alone, 108 central lymph node biopsy and axillary section. And there was no difference in local control, regional recurrences, overall survival in any oncologic outcome, confirming the hypothesis that radiotherapy is not inferior in the neoadjuvant setting. And in this trial, as you can see, where did the recurrences occur? 5 recurrences in level 1 to 2, so 3 in the central lymph node biopsy group, 2 in the axial lymph node dissection group. 6 recurrences were observed in level 3 or supraclavicular, regions that we would probably not reach by axillary section. And 2 recurrences occurred in the internal nodes, another region that we would probably not address with axillary section. And the edema rate was between 25% for axillary section and 9.4% for omitting axillary section. And this is a very recently published paper from the US with very similar data as compared to the Axana study. And it was analyzed the evolution of axillary treatment within the years. As you can see here, for patients with YPN1 disease, the omission rate of axillary section between 2016 and 2019 was between 28 and 21%. So in Europe, we are probably even more conservative compared to the US. So in the Axana, we have 25% omission in this cohort, and in the US, it's going up to 41%. And for micrometastasis, there's an increase of omission of axillary section between 40 and 69%. So we have about 60% in our. So this is what is being done in clinical practice in real world. So surgeons increasingly doubt whether axillary dissection is of benefit for the patients with comparing to radiotherapy. And these are the outcome data, overall survival. And in this trial, which was certainly observational retrospective data, but it was from the National Cancer Base, with included 6,000 patients. And the overall survival was even better in the central lymph node biopsy alone group compared to the axillary dissection group. But when adjusted to potentially confounded factors, there was no difference. So at least there was no difference between axillary section radiotherapy, but morbidity is much lower. Oops. Where can I go on? What happens? Okay, so another issue. Okay, thank you. I found it. So another issue is, what exactly is axillary section? Is this a standardized procedure? Some may go for level 1, a bit level 2. Are there still surgeons going for level 3? Are there still surgeons who are able to resect level 3? So is it a standardized procedure? I would guess it is not. So we can probably address this lymph node in level 1 or 2 with axial resection. But what about supra-infraclavicular? What about internal? So why should we remove a potentially chemoresistant node but leave other chemoresistant nodes behind? So this does not make really sense. Another issue that is discussed by radiation oncologists is the problem of the forgotten node. This is a paper published recently by Orit Kaider-Persson. In a time where we increasingly decrease axillary surgery, radio-oncologists identify increasingly forgotten nodes because surgeons do less radical surgery. So is surgery really a standardized procedure? This is a paper we have already seen on isolated tumor cells. Is axial resection of any benefit for patients who present with isolated tumor cells in the central lymph node? The ICAROS study clearly showed that there was no benefit in this patient cohort. We could then argue that there might be a diagnostic benefit from completion axial lymph node dissection in order to upgrade the end stage and then modify systemic or local regional treatment. But for the YPN0I plus group, PCR is defined by response to the breast in most patients. There are very few patients who have a PCR in the breast and could then be upstaged by axillary dissection and then maybe receive post-neoadjuvant treatment. In PN0I plus is considered non-PSR for systemic treatment. In patients with YPN1 micro and PN1, the end stage is already classified and the patient is already categorized as non-PCR, and patients with triple negatives and HER2 positive patients will undergo post-neoadjuvant treatment with T-DM1 or maybe with olaparib. There's no benefit anymore for detecting YPN2 in luminal tumors in the NATALEE era. It was in the MONARCH-E era where we tried to identify 4 nodes, but with the publication of the NATALEE trial, all patients are candidate for CDK4/6 inhibitors. There's no need to identify more nodes. And only very few patients with luminal tumors and BRCA mutation and a CPS-EG score 2-3, who might be upgraded by axial resection, would benefit according to the Olympia trial. So there's very little diagnostic information from completion axial resection that would modify systemic or local regional treatment. We will present our data on upgrade of micromets and isolated tumor cells at San Antonio in 2 weeks' time, and thanks to all GREC sites who supported the trial with many patients. So in conclusion, although axial lymph node dissection is the historic standard for YPN1, sentinel node target axis patients, and we do not yet have randomized data from Alliance, but on the other hand, we have no evidence that axial lymph node dissection is superior to radiotherapy, but we have a high morbidity. So in conclusion, regional recurrences are rare whatever we do. There's no reason and no evidence that chemoresistant cells are radioresistant. There's no reason why a technique that depends on individual skills and covers only parts of the target area should be inferior to a homogeneous cytotoxic treatment that can be tailored to all regions of interest. There's little diagnostic information from completion axial lymph node dissection that affects further adjuvant treatment, and axial resection is associated with high morbidity that affects quality of life. So please remember, lymph node surgery is diagnostic, not therapeutic. And focusing on lymph node treatment, and while focusing on lymph node treatment, we have to ask, do we miss the forest because of the tree? Thank you very much.
Thank you very much, Torsten. Now there is a vote. So you will see 3 questions on screen. You will have 20 seconds to vote on each question, and we will take the discussions afterwards. So please go to your QR code so that we can start dealing with that. Everybody done? No. Okay, while you're downloading it, I'm giving you a heads up. The first question is, should CN plus patients that have converted to YCN0 following neoadjuvant chemotherapy with ITC on SLNB, TAD, MLNB have a completion axillary lymph node clearance? Yes or no? Please vote. We'll give you some more time because it's more than 27 people in here. So we'll close that one. 75% of you would not offer completion axillary lymph node dissection, whereas 25% would. Let's move to the next question. And now it is the same question, but in the setting of a micrometastasis on sentinel lymph node biopsy, target axillary dissection, or marker lymph node biopsy. So would you offer completion sentinel lymph node, completion axillary lymph node clearance for these patients? Yes or no? You have to vote. More people would have to vote for that.
The timer did not register anything, so there we go.
Here you go, yeah.
About 50-50 maybe.
You still have 5 seconds to change these results. Okay, and now we're done. So the proportion is more or less the same. So in a total of 28, a little bit less than 1/4 would go for completion axillary clearance, whereas the rest would not. And now for the final question. I think that you can guess what the final question will be. So if you've got a macrometastasis during first surgery, would you go back to offer the patient a completion axillary lymph node dissection? Let's open it up and vote. Five seconds to go. Lovely. So the audience is afraid of the big bad wolf over 2 millimeters. Professor Mamounas, any comments on that?
Interesting results, and it's sort of expected to some extent. I think we all sort of agree that doing a dissection, at least for macrometastasis, is a standard, although we're waiting for trials. In our heart, we all know that probably it's not going to show any difference, and eventually we'll be able to avoid axillary dissection for these patients, but we're still waiting for the results of the randomized trials. But as was mentioned, in clinical practice, we often debate in our tumor boards, and sometimes we just don't do it, particularly if you have several nodes removed with only 1 positive or 2 positive, or you have done 6 or 7. We refer to the morbidity. We also in the US, we offer lymphovenous bypass more freely nowadays, and that at least helps us discuss with the patient an axillary dissection with a lymphovenous bypass at the same time. So it kind of sweetens the pill a little bit, and we hope reduces the risk of lymphedema. But I think the results are sort of what we expected. It's a tough topic for debate, But again, we're still waiting for more data. That's which hopefully will come not in the too distant future. We're still waiting for the Alliance 11-202 trial. Hopefully 25 or 26 will be when it will be reported.
Now, if I would have to put my money on something,
Yeah.
so if I had to organize and fund a trial of this magnitude, I would make sure that it is a safe bet.
I think a lot of people, myself included, will believe that it's not going to be a positive trial because radiotherapy was used in both arms, of course, of the study. So,
Okay.
questions?
I have a question for the audience, just a show of hands. So, for how many of you would the number of affected nodes make a difference in your decision to go for an auxiliary clearance, yes or no? So let's take the scenario of the 1 out of 4 nodes with a micrometastasis versus 3 of 4 nodes with a micrometastasis. How many of you would tip towards an auxiliary lymph node dissection if you had more nodes that were metastatic in that setting, albeit with a small burden? Don't be shy.
Yes.
Yeah. Okay. I had guessed as much. Okay. Any questions from the audience?
Yes, Professor Osman.
Thank you very much for this excellent discussion. Thank you very much for this excellent discussion. This topic is very controversial and hot topic. And we know from NSAB PB04 trial and also ACOSOC 11 and AMAROS trial show that there is no benefit of axillary lymph node dissection even if patients with positive sentinel lymph node. Our study also published in Cancer last month included 501 study and compared the patients with marked lymph node biopsy or targeted axillary dissection. And the result, 52 months of median follow-up results show that there is no difference between these two groups. It's a very low rate of local regional recurrence. We believe that auxiliary radiation therapy is enough to provide acceptable local regional recurrence rate. Thank you.
Thank you very much.
Yes.
I'm Dr. Natsiopoulos from Thessaloniki. Excellent debate, excellent discussion. I think it will be for some decades more, waiting for the results of trials. Okay, we have to face the master of questions, whether axillary cleaning, clearance, or is a therapeutic or an information, just an information. If we answer this question, we have the answer if the axillary clearance is a necessity after neoadjuvant chemo. We get the information just with one node. I think we don't need more information from other nodes planning the post-neoadjuvant treatment.
Thank you for this comment. I would just go and say, we'll talk about it during my second talk in the afternoon on that, but we are thinking, evidence suggests that we should be dealing with breast cancer in a much more multimodal manner. So I just think that the way that we will deal with it is that we will just need to realize that there are more than 2 or 3 tools in the box. Because right now we are thinking we had sentinel lymph node biopsy, we had axillary dissection, we put TAD or TAS or MLNB or however you want to call it. You can call it Isterbani for my part. But I think that the tools are not solely surgical and we need to go that way.
Thank you very much. Another question would be if not only the number of the affected lymph nodes after neoadjuvant would matter, or if the type and the number would matter, because it's another thing if you have a HER positive, if the type of the post-neoadjuvant therapy matters in your decision. How much benefit you expect from the post-neoadjuvant therapy in this setting. And I don't know if there are any studies, which is another question, if the immunohistochemistry of the lymph nodes is another one than this of the tumor. This would be interesting to know, the immunohistochemistry of the affected lymph nodes.
This is an insightful comment. I would like a response from Torsten on that.
So I think this was a very good question. The question was if the tumor biology, the immunohistochemistry would affect.
Professor Kagatani's question was if we would decide based on the remaining lymph nodes.
Okay, I got it. Okay. Well, I think for the HER2 positives and for the triple negatives, the number of nodes does not matter because we decide on PCR or non-PCR to give TDM1, or in triple negatives, in BRCA negatives, we discuss capecitabine, and for BRCA positives, it's olaparib. But the decision is not made on the number of nodes, it's made on PCR or not PCR. And the majority of patients, PCR is determined by the response in the breast. So there are very few patients where it's decided on the nodes. And having a higher nodal burden, N2 or N3, would not modify the systemic treatment decision. And only for luminal tumors, we do not have a real post-neoadjuvant approach except for patients with high nodal burden and BRCA mutation. And in these patients, this is the only small cohort of patients who benefit from discovering a higher nodal burden, which is expressed in the Olympia study by the CPSEG score, which must shift from 2 to 3. And this very small cohort of patients would benefit from additional olaparib. So this is why this is what I pointed out. We do not have diagnostic benefit from completion axial resection for post-neoadjuvant decision making. Your second question I thought was really very, very good. If there was a difference in tumor biology between lymph node and primary tumor. And I think this indeed is a very interesting question. I think we do not have enough information on that, but I think it would really be worth going further into detail.
Yes, and given that we're a little bit late, we're going to close it. I'll very quickly that in the HER2 positive setting, when the residual disease is HER2 negative, we still see benefit from TDM1 in residual disease. It's very unlikely an ER negative patient will become ER positive. So I think it won't really change much of what we do, even if the biology was a little bit different. So with that, I think we'll close the table. Thank you very much for nice presentations and discussion. And θα κάνουμε ένα 10 λεπτό διάλειμμα και θα ξαναγυρίσουμε.